So good afternoon. It is now 3:03, and this is voting list number 10, Friday, March 15, 2024. This is the Health and Government Operations Committee, and this is our last voting session for crossover. Okay, for crossover. I'm gonna stand by it, and there are no subcommittee meetings for crossover, okay? We'll be meeting again after Tuesday. But you know, we're working tomorrow, Saturday. We're gonna probably be on the floor most of the day on Monday because every bill has to pass over to the Senate by that evening. But I want to take a minute before we start to thank our three analysts because they have truly they work really hard. It's not just what you see here. It is at home. It is at nighttime at 11 o'clock at night. It is early in the morning at 6 in the morning, Saturday, Sunday. It is phone calls and it takes a lot. Okay. And I really am grateful to them because they make things smooth for us. When we're on the floor, things are smooth. You guys, they prepare us and you have what you need. And I am really grateful. I know I say it often, but you know what? You give people their flowers when they're alive, not when they're dead. Okay. You can smell it. You can see it. And to our staff in the committee, you guys, Michelle, your team is wonderful and you're flexible. And I'm very grateful. And lastly, to each member, I feel like a big mama bear on the floor because you make us look so good and you know your bills and you prepare for it. And I also love the fact that you're respectful and no matter what comes your way, you don't react. And I mean that. That is really very beautiful. And I thank you for all that work. And my vice chair, you're a dream vice chair. Okay. And I thank you. I told you that I appreciate you so much and you make my life so easy. So thank you. So let's go on to the withdrawals. We have 1, 2, 3, 4, 5 withdrawals. May I have a motion, please? The withdrawals have been moved in second. Any questions or concerns? Seeing none, all those in favor say aye. Any opposition? All right, they're withdrawn. Will be reported as withdrawn. We have House Bill 68, Delegate Stein, Continuing Care Retirement Communities, Governing Bodies, Grievances, and Entrances Fee. Favorable with amendment, it is Lisa and Rosenberg. Lisa.
This bill alters reporting requirements for continuing care retirement community providers related to grievances and contractual entrance fee refunds. The bill must be construed to apply only prospectively and may not be applied or interpreted to have any effect on the application to any cause of action arising before the effective date of the bill. There's amendments that start on page 1. They require providers to post the most recent disclosure statement on the provider's website. They require the provider to hold quarterly meetings open to all subscribers, and they require the last quarterly meeting of the year to include a summary of internal grievances. The amendments also retain current law for membership of provider governing bodies, require the governing body to make determinations of whether a matter is confidential, and specify that the department will annually collect information from providers on grievances and submit a report on the information to the Senate Finance and House HGO Committee. The amendments finally retain current law on terminated continuing care agreements and entrance fee refunds, but require a provider to submit a specified written report to a subscriber whose unit has not been reoccupied within 9 months and follow-up reports every 6 months until the unit is reoccupied.
Delegate Rosenberg.
Thank you, Madam Chair. These amendments are a compromise, work product of both sides on this issue. And I would also pay particular attention to the annual report, which would be an opportunity for us to find out, what issues remain, and it would then be up to the parties, obviously, to bring them before us at the following legislative session. So I believe it was unanimous, and I would move the amendments.
So the amendments have been moved in second. Any questions or concerns about the amendments? Delegate Shaliga.
What's the disclosure?
Give, hold on 1 second.
Do you mean, I'm sorry,
Well, you said that they have to post their most recent disclosure. I just wanted to know
Oh,
what a
okay.
disclosure was. It's on handwritten page 2.
Right,
provided for an existing law, but that doesn't.
yeah, that it is, something that's an existing law that they're now just gonna have to post on their website. But I'm trying to figure out exactly what, without cost of disclosure statement for each facility for which the provider holds a
Delegate Shalega, is it okay if we look at that answer before it hits the floor for you?
Certainly, that would be
Okay.
helpful.
Thank you. All right, and I appreciate the flexibility. And Delegate Hill,
So we had actually, I had a bill that also went, trying to get some more transparency in the CCRCs. And what came out of that hearing and the discussion afterwards, that there are already in statute, certain things that they're entitled to, certain rights they have. And rather than continue to push them, would this be a proper place to just ask as an additional amendment without derailing anything, that a Bill of Rights be created that can be posted in the CCRCs? I mean, they're saying that all these rights already exist, and to have them in a single document.
I would say Delegate no, I think that that should be a separate bill on its own where you bring all the stakeholders and you introduce the bill and we compromise on it.
Okay.
Okay.
All right.
So that we
Okay.
don't have a problem that they created something that is not in the interim. Thank you. Thank you. And while you're working on it, Delegate Hill, can you work with Delegate Shalega in the interim? I mean, get her input? Yeah, if you could get just, because she has a lot of experience with them, okay? Any other questions or concerns? All right, on the amendments. It's been moved in second. All those in favor say aye.
Aye.
Any opposition? Seeing none on the bill as amended. It's been moved in second. Is there a discussion, questions, concerns besides what we just discussed? Seeing none, all those in favor say aye. Any opposition? Seeing none, the bill passes. Who does not want to be on this bill? Can you raise your hand? Thank you so much. And thank you for the discussion. This is the place to ask the questions, okay? Because I want you to be comfortable. We have House Bill 119. It is Public Health Giving Infants a Future Without Transmission Gift Act. It was favorable with amendment. It was Aaron and Bagno. Aaron.
This is a departmental bill that alters terminology and requirements relating to HIV testing and reporting, including requiring universal syphilis and HIV testing for all pregnant women at the time of delivery, newborn HIV testing when the mother's HIV status is unknown, and inclusion of pregnancy status when reporting an HIV diagnosis. A hospital must determine the syphilis serologic status of a mother before discharging the newborn for the purposes of neonatal evaluation and treatment. The Maryland Department of Health is authorized to adopt rules, regulations, and standards regarding syphilis testing. There are amendments on page 5, and the amendments provide that the reports that are currently required under current law related to HIV reporting and any proceedings, recordings, or files relating to those reports are not discoverable and are not admissible in evidence in any criminal, civil, or administrative action. Under current law, they're only not admissible in any civil action.
Delegate Bagno.
Thank you, Madam Chair. This was unanimous and I would move the amendments.
Second. Any questions or concerns on the amendments? They be moved in second. All those in favor say aye.
Aye.
Any opposition on the bill as amended? It's been moved in second. Any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none, who does not want to be on this bill? Oh, You cannot, it's a departmental, right? House Bill 353, Maryland Department of Health 211, Maryland Oversight. It was favorable with amendment out of the subcommittee. It was Aaron and Bagno. Aaron,
This bill alters the definition of Health and Human Services referral system to mean a coordinated system for health and human service resources accessible to all state residents through 211 and other designated technology systems. The bill repeals the requirements that MDH, in consultation with 211 Maryland, evaluate the performance of each 211 Maryland call center, make recommendations to 211 Maryland regarding the quality of service provided by call centers or the performance of call centers when issues related to service quality and performance are presented to MDH, and make recommendations regarding corrective action to be taken by a call center. The amendment on page 6 requires the Maryland Board of the 211 Maryland Board of Directors to be expanded to include 2 representatives of 211 Maryland call centers nominated by the call centers. And on or before July 1st, 2024, the 211 Maryland call centers shall nominate the 2 representatives.
okay, who was this, Bagno?
Yeah, thank you, Madam
Okay.
Chair. This was, again, this was unanimous and I would move the amendments.
Second.
So it's been moved in second. Any questions or concern about this? There isn't one. Any other questions or concerns? Seeing none, all those in favor say aye. Any opposition? Seeing none on the bill as amended? It's been moved in second. Any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none, who does not want to be on the bill? Okay, so let's go to House Bill 411. Oh, yes,
I have an answer,
Oh.
phone a friend about the
Yes.
disclosure. It is a mandated document and most already post on their website. So
Okay.
you do not need to give me an answer.
okay,
I got
thank
it.
you.
Thanks.
Thank you for saying that. We appreciate it. And thank your friend. We have next House Bill 411, House Bill 411. House Bill 411, Delegate Kipke. Public Health Opioid Overdose Reversal Drug Standing Order. Oof, it was favorable with amendment. It is Aaron and Bagno. Aaron,
There's a reprint of the bill on page 7. The amendments strike the bill as introduced and instead require that on or before December 1st, 2024, 2025, and 2026, the Department of Health will report to the Senate Finance Committee and HGO on current opioid overdose reversal drugs that are approved by the Food and Drug Administration. And for any of those drugs that are approved, whether the department has added the drug to a standing order, and if not, the reasons why the drug has not been added.
Bagno.
Thank you, Madam Chair. We did consider this bill earlier this week. It's been a week of 411, 211, 988. Who's on first? But this was unanimous and I would move the amendments.
The amendments have been moved in second. All those in favor say aye. Any opposition? Seeing none, and the bill is amended. Is it moved in second? Any discussion or concerns? Seeing none, all those in favor say aye. Any opposition? The bill passes. Delegate Kipke, congratulations. That's a good bill. Who does not want to be on the bill? We all want to join Delegate Kipke, right? Okay, so let's go on to House Bill 464, Delegate Martinez. It is Health Occupations Practice Audiology Definition, favorable with amendment. It is Lisa and Rosenberg. Lisa.
The bill specifies that practice audiology means to evaluate, diagnose, manage, and treat auditory or vestibular conditions in the human ear, prescribe, order, sell, dispense, or fit hearing aids to an individual for the correction or relief of a condition for which hearing aids are worn, prescribe, order, sell, dispense, or externally fit a sound processor to an Osseo integrated device, and prescribe, order, sell, or dispense or externally fit a sound processor. There are amendments on page 9 that clarify that the definition of practice audiology is limited to removal of foreign bodies and cerumen from that does not require anesthesia. And it limits it to ordering cultures, blood work, and imaging related to conditions of the ear.
Okay,
This, as you may recall from the hearing, was heavily debated by the two sides. They reached agreement on most, but not all of the issues. And the subcommittee unanimously agreed with as far as they had gotten and with the audiologist position. So this was unanimous on the subcommittee this morning.
okay, do you want to move the amendments?
So moved. Thank you, Madam.
It's been moved in second. Any questions or concerns? All right, seeing none, thank you, Delegate Rosenberg, for your questions, for your work, Delegate Hill.
Yeah, so I spoke with the sponsor about an hour ago, not because as the chair said, there was partial consensus. There were still some opposition from one of the sides, and they asked me to take a look. I'm not on the subcommittee. And I took a look at their rationale and I offered some additional language that I've given to the delegate and to Gil Jin, and he was going to run it by, and I just needed to know if there may not have been enough time, in which case, has he gotten back to you at all, Delegate Martinez?
Yes, so the audiologists were able to get back to me. Unfortunately, they're not going to be able to accept these amendments. We really do feel like the exclusions that you put in the amendments would force referrals on everything prior to audiologists being able to evaluate, diagnose, manage, and treat the conditions that they currently have right now within the practice scope. And so we are going to move the bill as amended in subcommittee.
All right. Thank you.
Thank you. And I know that you have made many attempts and have met many times, and there's just no agreement, okay? And we try really hard. And this is the language used in some of the boards, correct?
Yes, and I can speak to that. I
Can
do
you
want to thank
please?
all stakeholders for the little over 5 to 6 meetings that we had since December, when the ear, nose, and throat doctors received the copy of the bill. The amendments were done in consensus. The audiologists were able to concede on some of the definition and making sure that it was very clear that they will do everything up to surgery. Colorado and Alabama already have similar language in their statute, but also the VA, which practices in all 50 states, has similar definition for scope of practice for audiology, which is why we felt like it was appropriate. In addition, the licensure for audiologists requires that they diagnose, treat, and manage these conditions. And so this bill is very simple. It just allows our audiologists to practice to the full scope of their licensure, and I move the bill.
Okay. So it was the amendment, you moved the amendments. All right, so any other discussion on the amendments? Delegate Hill.
I just want the committee to be aware that some of the things that the ENTs wanted to be also excluded were infections of the ear, that audiologists should not be treating infections of the ear, and that they should not be treating lesions of the ear. And so without those amendments, they will be treating infections and they will be treating lesions. And the other part was vertigo unresponsive to the repositioning maneuver. So if someone has vertigo and they don't respond, as the bill is amended now, they will be able to follow that however they want. And the ENTs really felt that vertigo, because there can be any number of causes other than the inner ear, that would require, at least in the language I had for some of these other asymmetric hearing loss, except in coordination and collaboration with a treating physician, conductive hearing loss, except in collaboration and coordination, and vertigo and infections of the ear and lesions of the ear. So those are not in there. And so as we pass this bill as amended, we're saying we're fine with audiologists treating infections, lesions, and vertigo that does not respond to manipulation.
Delegate Martinez.
Oh, I'm going to go line by line under all the things that you just named. Again, I'm not a clinician, so I'm going to do my best to play doctor with you. But I will say before I do that again, we've been meeting with these folks since December, and we got these amendments an hour ago. Regardless, I know you had your additions to try to make them a little bit more palatable. We've been trying to get to the place where we've gotten an hour ago and we're unable to. And I also want to mention, just for the good of the body, that this bill already passed second reader amended in the Senate and will be on third reader today. So I do want to just mention for the asymmetric hearing loss, there's no way that you can determine asymmetric hearing loss without first having an audiologist evaluate and try to diagnose that is hearing loss. Under ICD-10 digital diagnosed codes, there is no ICD code specific for asymmetric hearing loss. For conductive hearing loss is often a temporary hearing loss in one or both ears, earwax, ear infection, swimmer's ear, and there's no way that there can be conductive hearing loss if conductive hearing loss is presented until an audiologist evaluates and then diagnoses that hearing loss. Same with vertigo. For the imbalance, spinning, dizziness, if there's unresponsiveness during the test, they ultimately will then go ahead and make the referrals to the ear, nose, and throat doctor. Infections of the ear, the current legislation already addresses that audiologists will only address the external artery canal of the ear and would have to refer out to ear, nose, and throat doctors.
You can continue.
Yeah, and so lesions of the ear, patients do not know if they have a lesion in the exterior outer ear canal until a provider, a primary care, audiologist, dermatologist looks at the external ear canal using a specialized visual tool. Individuals who also purchase online things that they can look into their ear canals themselves can view lesions, and they are free to seek care to any provider that they choose that they feel like is the most effective pathway. If they choose an audiologist for the initial appointment, passage of this legislation will allow for the audiologist to manage and refer patients to the appropriate dermatologist or ear, nose, and throat surgeon and provider. I think, again, what we have is something that we all can be proud of, and I think this is a byproduct of consensus.
Okay, Delegate Hill, did you want to respond? quickly?
Sure. I just wanted to say, I think that you make good points, and what the issue now, as you explained it, is there's a difference between saying may diagnose and treat. And I think what this was going about, if they can diagnose it, then they should know not to treat it. What you said is they'll know that, but the bill says that they can treat it. And so maybe it's that under these, unlike the first ones that you all agreed to, that maybe some of these is once diagnosed, they shall refer and treat, or something like that. And I know it's not about holding the bill up, that's why we're having the conversation. But there are good people who practice in every field, and there are people who take it to an extreme, right? Who will then go ahead and say that that's what this committee does. It tries to make sure that the boundaries make sense. And if it were a matter of saying to tweak it further and take out, you don't like the red except in coordination, take that out, take out asymmetric hearing loss and say, treating asymmetric hearing loss. Maybe it's not diagnosing. Or and to your point, asymmetric hearing loss, and don't include that, because if they take the earwax out, it's no longer hearing loss. I hear you. Maybe it's language that says within, boundaries. I don't know, but I have a problem with infection of the ear. I don't care where it is. I don't care where it is. You can diagnose it, but I don't know who should be treating an infection of the ear. And same thing. So maybe it's about the diagnose and treat as opposed to once diagnosed, refer to treat, following conditions, infections of the ear, lesions of the ear, and maybe it's just those two.
And the diagnose and treat, that language is again in the other similar boards. Let me ask Delegate Shalega and then Olston, please.
Thank you. So, this question, and first I want to thank you for all your hard work on this, Delegate Martinez. And, I know it's been a lot. I wonder if an audiologist can actually treat an infection. I guess that'd be for a Delegate Hill. I mean, they can't prescribe antibiotics.
They can treat like you can. They can say, put antibiotic on it, like get some bacitracin, right? But that's not because of their scope as an audiologist. That's them telling something, but they can't prescribe. So I don't know how they're treating infections, but you had an answer there about it.
Delegate Ashanti, Martinez.
I've been Ashanti much longer than I've been delegate, so I'll take it.
Thank you.
The Board of Examiners already knows that healing is not part of the legislation. Healing is part of the practice of medicine. And so we do not feel like it should be added, because we understand that audiologists will not be doing the practice of medicine. And so again, this bill is allowing audiologists to practice to the full extent of their licensure Colorado, Alabama already have diagnose, manage, and treat, those 3 words in their statutes. The VA has it in their statutes. Other states have, whether it's just treat or manage, whether it's treat or diagnose, whether it's just treat, but this is not language that is out of what I feel like should be the scope of what they learn. I also want to add that we were able to call other states because there has been many amendments by the ear, nose, and throat doctors to slow down this bill. And we called those states. We asked, why does it say non-medical? Why does it say this? And they said, because we haven't updated our statute in 20, 30 years. This is to modernize what is happening right now and to be able to provide greater patient care. And so I really do think that this bill does that.
All right, I'm going to call on Delegate Alston and then I'm taking the vote, okay? Delegate Alston.
I was actually just going to echo the question of Delegate Shalaga, which to me seems like if they are not allowed to do it, they would be practicing medicine without a license and they would get in a lot of trouble for doing that. But I don't think that what's in this bill is a problem. I think that the bill is fine as written. And I think anybody going outside trying to treat somebody with prescriptions, they're going to be outside of the scope of their practice anyway, because you can't write a prescription for an infection. And they would probably lose their license, I would reckon, if they're trying to do stuff like that.
Okay, we're going to we had a nice discussion. We heard from both sides respectfully. We have a full agenda. I know personally that the parties have been trying really, really, really hard to come to an agreement, but sometimes as much as we push it here, sometimes it doesn't happen, right? And then the committee has to make a policy decision intelligently. And I'm going to take a vote on the amendments. They've been moved in second, correct? Can you move it and second it? We moved in second. All those in favor say aye.
Aye.
Any opposition to the amendments? On the bill as amended, is there a motion? It's been moved in second. Any discussion on the bill as amended on anything that we didn't discuss prior? All right, seeing none, all those in favor say aye. Any opposition? Delegate Shalaga, Delegate Morgan, Delegate Hutchinson, Delegate Riley, Delegate Kipke, okay? And Delegate, I said Chisholm, so all of party line, okay? All right. Thank you, everyone, for the discussion. Thank you for being respectful. The bill passes. Who does not want to be on the bill? Okay, Shalaga, Chisholm, Morgan, Riley, Hutchinson, Hill, Kaiser, Kipke. How you like that? That was very slow, right? Definitely not what I'm feeling inside, but I am very slow, going very slowly. Okay, let's go on to 598, discrimination, military status prohibition, favorable with amendment. Lindsay and Kerr.
As introduced, this bill generally prohibited discrimination based on an individual's military status in a variety of portions of the statute. The amendments that begin on page 10 in your packet from the sponsor prohibit discrimination only for the purposes of housing and employment and not in those other areas of law, and strikes veterans from the definition of military status. So it would just apply to active duty military and their dependents. And it also adds a special section at the end of the bill saying that the act may not be applied or interpreted to limit the authority granted to the Attorney General under Title 20, Subtitle 10, Part 3 of the state government article. Those are provisions that generally grant the Attorney General the power to investigate, prosecute, or remediate any conduct that constitutes a civil rights violation, and it requires them to coordinate with the Commission on Civil Rights when they are investigating those types of complaints so that they do not duplicate their efforts.
Okay, may I have Delegate Kerr speak, please?
Yeah, thank you, Madam Chair.
Thank you.
I want to thank Delegate Alston for pointing out some initial flaws with this bill, and Lindsay for figuring out how to write it. And Delegate Boafo worked really hard on this bill. So I would move the amendments.
The amendments have been moved in second. Any questions or concerns about the amendment? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none on the bill as amended? It's been moved in second. Any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none, the bill passes. Who does not want to be on the bill? Okay, let's move on to House Bill 806, Physician Assistant Revisions, Physician Assistant Modernization Act of 2024. It is favorable with amendment. Lindsay and Rosenberg. Lindsay.
This bill requires a physician assistant to have a collaboration agreement rather than a delegation agreement, and authorizes a physician assistant who has submitted a collaboration agreement to State Board of Physicians to practice medical acts that are authorized under a license issued by the board and the PA's collaboration agreement, rather than medical acts that are delegated by a supervising physician under a delegation agreement. A physician assistant may perform additional duties within a PA scope of practice as specified. And the bill also alters education and examination requirements for licensure and makes other conforming changes. The amendments, there's a reprint that begins on page 12 in your packet. I promise this is a shortened version of the description. The amendments add physician assistants to the definition of healthcare provider for the purposes of certain provisions of law governing healthcare malpractice claims. Authorizes a physician assistant to delegate medical duties under certain circumstances and with a certain number of hours of clinical practice experience. Rather than submitting collaboration agreements to the board, the amendments require the physician assistant to provide notice to the board of the executed agreement and of the practice team physicians listed in the agreement, clarifies what medical acts a physician assistant may perform, removes language requiring a certain period of mentoring for new physician assistants, specifies the circumstances under which a physician assistant is required to obtain board approval to perform advanced duties, including the practice settings in which a physician assistant may perform advanced duties without board approval, and the minimum number of clinical practice hours a physician assistant must have to perform advanced duties without board approval, establishes the board's authority to modify a collaboration agreement or the delegation of an advanced duty under the agreement, establishes requirements for a patient care team physician to delegate prescribing and dispensing of controlled dangerous substances, prescription drugs, or medical devices to a physician assistant under a collaboration agreement, and makes conforming changes.
Okay, thank you. That was Delegate Rosenberg.
Well, that summary was the result of 3 years of this bill being before us. Yes, indeed, 3 years. And so the parties in this instance, along with the sponsor, did reach agreement, and the vote in the subcommittee was unanimous. Move the bill, move the amendments.
Let's run quickly before it takes 3 more years. All right, is it moved in second? Any questions or concerns? See none. On the bill as amended. Second, it's been moved and second. Great. Any questions or concern on the bill? Seeing none, all those in favor say aye.
Aye.
Any opposition? Great. 3 years. 3 years. All right. I want to take a minute to say thank you to the sponsor, Lisa, Rosenberg, Lindsay, Rosenberg, and all the parties involved. Thank you so much for working on this bill. And Delegate Kerr, you are a miracle worker. Thank you. It took a village, everyone, Robin Elliott, Steve, everyone. Thank you so much. Okay, let's move on to House. Who doesn't want to be on that bill? All right, let's move on to House Bill 822, Delegate Collison, Maryland Medical Assistance Program, employee individuals with disability. It was favorable with amendment. It is Aaron and Bagnall. Aaron.
There's a reprint in your packet on page 48, and that mirrors Senate Bill 970, I believe, which was not marked as a cross file, but it was introduced in a very similar fashion to House Bill 822. So that is the markup of that version as it has passed Senate Finance. And in that version, the bill requires the Department of Health to provide employed individuals with disabilities program services to qualified applicants, including existing Medicaid recipients who are at least 16 years old, for initial applications for the IED program services, accept documents to verify income and resources, transition Medicaid recipients who become eligible for the EID program in a manner that is least disruptive to the recipient's access to services, ensure that the application process for the EID program provides maximum flexibility and plain language information for applicants, and establish premium contributions. Now, there's also an amendment on page 53 that was adopted in the Public Health and Minority Health Disparities Subcommittee And this amendment provides that on or before December 1st, 2024, the Maryland Department of Health will report to Senate Finance and HGO on the fiscal and operational impact of implementing an employed persons with disabilities program that serves individuals age 65 and older, including options of eliminating or increasing the age cap with enrollment and establishing a premium contribution for EID program services that is based on an applicant's earned and unearned income.
Oh, thank you so much, Delegate Bagno.
Thank you, Madam Chair. This was under the theme of It's Complicated, which was a subcommittee. And the subcommittee really wanted to do something, so this was unanimous and I would move the amendments.
All right, it's been moved in second. Any questions or concerns on the amendments? Yes. Oh, yes. Tyson.
Thank you, Madam Chair. To the subcommittee chair. Given what was described about the amendments, when this bill was brought in, one of the people testifying was going to be turning 65 later this year and losing some of her benefits. Was that part of the bill maintained or addressed? Besides the study piece, was there something else?
Go ahead, Vice Chair.
Thank you, Madam Chair. I am actively working with the Medicaid department on making sure that we find a program that she will be able to enter when she turns 65 to continue the services that she's currently receiving.
And presumably the other people that age will find out.
We'll try, yes.
Okay.
Thanks.
Thank you. Yes, thank you. Any other questions? All right, on the bill as amended, all those in favor of the amendment say aye.
Aye.
Any opposition? Seeing none? Oh, yes,
I'm sorry.
it's okay.
Just very simply explain what it does. It's just a study now? Is there anything that it does beyond the study?
It's not just a study.
Can you explain what it does
Yes.
for him?
I
Thank
mean, I
you.
don't need a lot of detail, just
Sorry, I'm pulling back up.
Okay, take your time.
Here we go. So it basically codifies what MDH is already doing with the employed individuals with disabilities program services. They have to be provided to individuals who are at least 16, and then for the applications, the documents that they have to accept, and then the requirement that they transition recipients who become eligible for the program in a manner that is least disruptive to their access to services. And they establish premium contributions. So the issues that are not currently being provided are the bill as introduced would have repealed that age cap at 65. That's going to be studied, the effect of eliminating that, and then the counting of the spouse's income, looking at that.
Okay.
And when it comes to premium payments.
Thank you for the question, Delegate. And I want to thank everyone for working on it. I know that it's not everything we wanted, but at least it helps, right? So thank you so much. And it keeps us at the table. So go ahead.
Madam Chair, if I
Yeah.
might, I actually spoke with Josh Basil, who brought this to us early this morning. And I am committed to continuing to work with him, and I fully expect that we will be back here next year with some program recommendations. Another piece of the bill that I think is very helpful asks the department to meet with the coalition that Josh leads at least twice. So, and we may even meet more than that, but in order to help find the right way to deliver these services to these folks.
Got it. All right, we were on the amendment on questions. Any other questions or concerns? All those in favor of the amendment say aye. Any opposition? Seeing none on the bill as amended? It's been moved in second. Any questions or concerns? Seeing none, all those in favor say aye. Any opposition? Seeing none, the bill passes. Who does not want to be on the bill? All right. We have next House Bill 876, Delegate Johnson, S. Johnson and A. Johnson. Health insurance, I wanted to say that, Johnson and Johnson. Health insurance pharmacy benefit manager, specialty drugs dispensed by a physician. It was voted favorable with amendment. It is Lisa and Collison. Lisa.
There are amendments on page 54 of your packet, and as amended, the bill prohibits carriers from excluding coverage or coverage, for covered specialty drugs administered or dispensed by a provider if the provider is an in-network provider of covered medical oncology services that complies with state regulations, and the covered specialty drug meets specified criteria. The amendment also specifies the reimbursement rate and provides an exception for failure to satisfy medical necessity criteria.
This is Delegate Collison.
Thank you, Madam Chair. This is a bill you've seen a number of years. And we weren't able to move it because it really changes the way the drugs, prescription drugs are delivered to a certain population. So, but this bill, we're willing to take the risk. We want to see how it works, and I would move the amendments.
They've been moved and second. Are there any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none, the amendments pass and the bill is amended.
Move the bill as amended.
It's been moved in second. Any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none, it passes. Who does not want to be on this bill? I have to say that when we are done, God willing, with session, I want you to look at the work we have done here. And this is a good bill. This is gonna help people. It really does. And you're gonna feel very proud of the stuff you have done. But this is one that I love very much. And Delegate Johnson, thank you so much for your leadership, okay? Thank you. Delegate, and I know Lisa and Collison are the insurance queens. Thank you for your work. 932, Delegate Collison, Health Insurance Utilization Review, Revisions, Favorable with Amendment. It was Lisa and Collison.
This bill alters and establishes requirements and prohibitions relating to health insurance utilization review, including prior authorization of prescription drugs. The bill also alters requirements related to internal grievance and adverse decision procedures and establishes transparency provisions for patient benefit information and the claim review process. There are amendments on page 57. Amendment 1 makes clarifying changes. Amendment 2 alters the provision relating to prescription drugs and reauthorization requirements by requiring a carrier to allow a patient to remain on a prescription drug if it's for the treatment of mental disorder, was previously approved by the carrier, and the prescriber attests that the drug continues to be necessary to effectively treat the patient. Amendment 3 requires the Maryland Healthcare Commission to monitor and report on progress toward implementation of electronic prior authorization and real-time benefit check technology instead of establishing a work group.
Delegate Collison.
This bill is a product of 6 months of work of all of the stakeholders. We were not able to go as far as we could. You'll recall in the hearing, we had a $93 million fiscal note. We worry about that note, but it was what we had to deal with. So in order to get the fiscal note down, we had to limit the reauthorization, not pre-authorization. That still exists, but the reauthorization for mental health drugs will be by attestation now. There isn't going to be a long process by which the provider has to complete it. So the rest of the bill are things that providers really wanted, and the use of the real-time benefit technology is going to make things much more efficient. So with all of that, I would move the amendments.
The amendments have been moved and second. Any questions or concerns? I saw first Delegate Hutchinson, followed by Hill.
Thank you, Madam Chair.
You're welcome.
Thank you, Vice Chair. I know you worked very, very hard on this. In fact, I remember this hearing quite well when the chair was taking pictures of Matt sitting up there in agreement of this. I remember 3 panels later that Ms. Swanson from Care First came up and testified, and I asked her a question: is Care First in favor with this bill as amended? And at that time, she said, yes, they are. I understand the Care First after that came back and significantly changed this bill. So how much did that Care First coming back change this bill? And also, do we really believe the fiscal note is accurate?
We don't have any authority over the fiscal notes, and we have to depend on others to gather the information and data that can be used to inform us on that. It seemed rather high to me, and I think that was why Care First came in without support, much more of a neutral position. We did respond to a couple of requests that they had for amendments that didn't substantively change the bill. But in the end, they felt like it was too expensive or would be too expensive to deliver. And that was the struggle we've been having in the last couple of weeks. We feel like we've met a place where we can at least get the bill started, all the other processes started, and we're going to watch and see how it affect, what the fiscal effect is on the mental disorder medications, and then also look at other states in terms of how they're operating, where they've changed their reauthorization processes.
So you see this as a good start?
I do. I would have liked a better start, but I see it as a very good start.
Thank you.
And if I may add to that, there was an agreement of everyone, as you clearly stated. And around here, all you have is your word, right? After 6 months of working. So it was kind of shocking to see that position, and especially when Washington, D.C. requires it, and Care First is the carrier in Washington, D.C., and they do it exactly what we have. They can, and their language is even stronger, where they cannot do it based on cost. It has to be medically necessary. So I don't know why the people in Maryland cannot get the same benefit, right, from the same carrier. But I want to thank our vice chair for her hard work, because she worked very hard on this. They had 11 meetings where all the carriers were present and had someone present. And they had many, many, many emails where all the carriers were communicated to each and every one of them. And they were all in agreement. And then it just changed at the last minute. And as you know, we don't operate like that here. So I hope that we all learned our lesson, that all we have here is your word, right? We're here for 90 days and we have to trust each other. And I understand their concerns, but it's not like they were not at the table since last summer. So anyway, thank you for your question. We're going to move forward. There's always another year, another session, and we're going to hope, and we know that this will help a lot of people that we heard here in this committee, right, that need this kind of help. It should be, the decisions should be based on medical necessity. Delegate Hill. And for example, if you look at, you were not here when we did step therapy, but we did step therapy, and it's the same thing here. We have been doing it for 10 years and the sky has not fallen. So we have precedent to show that it's not going to fall. But we're going to do baby steps. It's okay. We can do it. We're ready to do the work. And this is a good step forward. Delegate Hill.
Yeah, thank you. So I first want to congratulate the vice chair and the chair for your commitment to getting this done. I just would ask the vice chair, I listened to all the amendments. Can you just simplify for me, for someone prescribing psychoactive medications, what is the process after this goes into effect? Because you talked about if they affirm that the diagnosis is the same, is that they have to reaffirm every month, every 6 months, every year? I mean, what's the process now?
I believe it's annual, and it's just an attestation saying this medication is still necessary.
Okay, so, all right. And at
There's no documentation required. As right now, under current practice, there could be, multiple forms that are required, and over, a number of days. And if you don't produce the right forms, then it starts, the timeline keeps going.
So that I'm clear, when I explain it to people, when they write the prescription after a year, or the insurer will send them to their office a form saying, you've got these 20 people on medication, we need you to affirm the diagnosis. How does that reaffirmation And I mean, obviously, the simplest thing, which they're not able to give us, is that if I write the prescription, it must mean because I want them to be on the medication, right?
Right.
That's my affirmation. I wrote the prescription again. But what are they requiring and how would this be done?
Well, we don't have specifics in the
Okay.
bill. I mean, each carrier and is going to have to work out their own process, but all we know it's a simple sentence.
Okay.
You know, and
All right.
they will have to figure out, but you know, it is annually, it's not
Not
frequently.
Okay,
no.
thank you.
Okay. Delegate Bagno.
Thank you, Madam Chair. And I just want to thank the Vice Chair for your work on this. And try and working to find a less challenging way to make sure that the continuity of care for our folks who are struggling with mental illness and the maintenance of their care. We know that mental illness is still continues to be stigmatized, and there are already barriers built into the system. So thank you for reducing a barrier, and I hope that that we can continue to move forward and remove the barrier entirely. Thank you.
All right, thank you so much for the discussion, and thank you again, Delegate Collison, for your grace and patience. I'm going to take the vote on the amendments. They be moved in second. All those in favor say aye.
Aye.
Any opposition to the amendments on the bill? The bill has been moved in second. Any questions or concerns on the bill? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none, who does not want to be on the bill? Thank you. I appreciate it. Next, House Bill 933, Delegate Fellmark, Behavioral Health Crisis Response Service 988, Trust Fund Fees, favorable with amendment, Aaron and Bagno. Aaron.
There is a reprint of this bill that starts on page 59, and that mirrors the cross file of the bill that is on third reader in the Senate. So the House Bill 933, as amended, establishes a state 988 fee with a structure and application modeled on the state's 911 fee. The 988 fee is set at 25 cents per month and applied on specified 988 accessible services in Maryland. Fee revenues accrue to the 988 Trust Fund to support the eligible uses of the fund. The amendments establish a cap on administrative expenses for the Comptroller's Office of 6% for 3 years, then 3% beginning in fiscal year 2028. The amendments exempt the federal Lifeline program from the fees and delay implementation of fees on prepaid wireless until 2027.
Delegate Bagno.
Thank you, Madam Chair. This is the bill that made me want to put in a bill that says if there's a phone number, the House bill number needs to be the same. Once we figured out that we were talking about the 988 Trust Fund on House Bill 933, the bill passed unanimously, and I would move the amendments.
The bill has been moved in second. The amendments have been moved in second. Any questions or concerns on the amendment? Seeing none, all those in favor say aye. Any opposition? Seeing none on the bill as amended. It's been moved in second. Discussion. Delegate Morgan and Delegate Shalega.
Thank you, Madam Chair.
My pleasure.
So do we feel like the fiscal note after the amendments are accurate and it's going to raise $22 million in fees?
And I'm seeing yes by Delegate Bagno.
Okay, thank you.
Correct, Delegate Bagno? I saw your head move.
So I'm pulling up the fiscal.
Okay,
So
let's wait. Want to be accurate?
I just want to say that the stakeholders who brought this to us actually spent the interim looking at what would be needed to keep the 988 trust fund sustainable. And this was what they brought to us, and I believe that the fiscal note is accurate.
Okay. All right, Delegate Shalega.
So this is going to be $22 million a year tax on people with a cell phone.
Delegate Bagno.
This is 25 cents, but yes, it will raise revenue to keep the 988 trust fund sustainable.
Thank you.
Okay, and Delegate Bagno. What does the 988, can you explain what it does?
So the 988 Trust Fund was established to support the call centers and also a series of grants that also support the work of the 988 call centers and our suicide prevention efforts.
So the 988 is a hotline for what?
988 is suicide prevention. And for people who are in crisis, they can call, they can text. And the 988 is a national number, similar to 911, that people can use when they are in crisis. And the 988 Trust Fund was established to ensure that we could sustain call centers here in Maryland. Right now, Maryland actually has a 90% rate of calls within the state. If there isn't a call, if the call center doesn't immediately respond, it is directed to another call center, but we have a 90% call response rate within the state.
And have those numbers gone up, people in crisis?
They have gone up, I believe, 400%.
Thank you. Delegate Rosenberg.
Thank you, Madam Chair. And this 25 cents per person per phone would enable the maintenance of existing service. Any increase in service or just maintenance?
It allows us to expand.
Thank you.
Thank you. Okay. Delegate Kipke.
Easy for you to say. How has this been funded so far?
It was originally funded with an appropriation last year. But we knew that would only sustain the fund, I believe, for the first 3 years. I don't have it in front of me. I can pull that up. But during the interim, the stakeholders were charged with finding a way to continue to sustain it, because although the number is federal, how the states implement it is up to the individual states.
Okay, and have we looked at how the other states have funded it?
That I don't know.
I just asked because that might be a question that's asked.
Okay.
And I appreciate that. And I can get the answer. I don't have it in front of me, but
Okay,
but I
That's a
can.
good question.
thank you.
Thank you, Delegate Kipke, for the question. Delegate Morgan.
You don't have to get this information to me right now, but I would think a question would be asked. There's some of us that feel that there's a lot of slush money in some of these special funds, like the money is collected for the best reason possible. And then these funds build these massive overages, and then that money gets scraped back to the general fund. We saw that under the Malley administration. So you probably might get a question here that how much money is currently in the fund? And I bring this up because last year we increased the 911 fees, which I would have thought there was money from 911 to go to this. And I remember there was massive overages and the money wasn't used. And I believe we upped the fee again last year on 911. So it's just something I would prepare for those questions. Thank you.
Thank you. And we appreciate the discussion. Are there any other questions or concerns? Delegate Shalay.
Thank you. I don't know if this is correct, but the Google machine tells me that in 2020, the combined federal, state, and local taxes on cell phones is at 24.78%. So I think this is a laudable program, but if we're already taxing cell phone users, why aren't we using that money that we're already taxing them with? So for the floor leader, that might be some good information for you to know.
Have a 988 fee, and we can't use the 911 fees for 988. So this is a non-discretionary fund. This is specific. This trust fund is specific to 988.
And thank you for the questions. We really appreciate it and the discussion. Absolutely. This is the place and we welcome it. So I moved the amendments, right? Delegate Riley, I'm sorry.
I'm sorry. I was a little late.
It's okay.
So do we know that this fee is going to be sufficient, or will the counties, because I heard from a couple counties that said that they cannot afford this if it actually falls on their backs. Are they going to have to pay a portion of this? Do we know going forward, or is it just?
You're talking about
fee?
the trust fund?
Yeah.
This was designed to be sustainable, because a lot of the grants actually do go to our local county call centers.
Okay, all right, thank you.
Thank you. Thank you for the questions. They were great. So I did move the amendments, right? And second, and we had discussion. So all those in favor say aye.
Aye.
Any opposition? All right, on the bill. So we moved in second. Any questions or concerns besides what we just discussed? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none, the bill I'm sorry. I'm too fast. I'm too fast. Delegate Shalega, Delegate Morgan, and Delegate Kipke.
I'm gonna vote no now, but just want to research to see if other states come up with ways to fund this stuff.
Thank you, Delegate Kipke. All right. Thank you very much for the discussion. We're going to go on to House Bill 1056, State Board of Pharmacy. Actually, the 988, who doesn't, I went through that already, right? Who does not want to be on that bill? Can you raise your hand? Delegate Shalega and Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, and Delegate Kipke. Thank you. 1056, party line. 1056, State Board of Pharmacy Prohibition on Discrimination Against 340B Drug Distribution. Favorable with amendment. It is Lisa and Carlos. And Lisa.
This bill prohibits a 340B manufacturer from directly or indirectly denying, restricting, prohibiting, discriminating against, or limiting the acquisition or delivery of a 340B drug to a pharmacy on behalf of a covered entity. Violation is an unfair, abusive, or deceptive trade practice under the Maryland Consumer Protection Act and is subject to specified enforcement actions and penalties. There are amendments on page 71. Amendment number 1 is technical. Amendment number 2 clarifies that the provisions of the bill only apply to 340B manufacturers, but that an investigation of a violation of the provisions of the bill may include a wholesaler or third-party logistics provider. The amendment clarifies that alleged violations committed by a person that is not licensed or permitted by the Board of Pharmacy will be investigated by the Consumer Protection Division of the Attorney General. Reduce the penalty from $50,000 per violation to $5,000 per violation, and requires the Prescription Drug Affordability Board to conduct a study on the 340B program, including the implementation and impact of the bill.
Okay, go ahead, Delegate Gollison.
So, given what Lisa just said, and this will allow other pharmacies that were asking for the ability to deliver these drugs to covered entities like Healthcare for the Homeless to do so, and I would move the amendments.
They've been moved in second. Any questions or concerns? Seeing none, of those in favor say aye. Any opposition? Seeing none, and the bill is amended. Is been moved in second. Any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none, the bill passes. Who does not want to be on the bill? All right, that was a great bill. Thank you, Delegate Gazzoni. House Bill 1122, Maryland Healthcare, and we have left 24 minutes. We have to be on the floor at 4:30, okay? So please keep that in mind. And let's just leave it. Let's do it. Maryland Healthcare Commission Nursing Homes Acquisition, favorable with amendment, Lisa and Rosenberg. Lisa.
This bill requires a person at least 120 days before making a contractual arrangement for the acquisition of a nursing home to submit a request for acquisition to the Maryland Healthcare Commission and provide specified notice to the residents and staff of the nursing home. There are amendments on page 74 of your packet. They clarify when a provider is required to provide notice of a change of ownership or submit a request for approval of an acquisition. They require the executive director to complete a review of an acquisition request within 45 days. They authorize the executive director to consult with the secretary's designee It required the commission to make a final decision on an acquisition referred by the executive director within 60 days. Require notice of final decisions and reports to be provided to the long-term care ombudsman. Allow a person acquiring ownership to temporarily delicense beds for 3 years to reduce the number of rooms with more than 2 beds, and authorizes the commission to extend the 3 years for good cause shown. Clarifies the criteria the commission will consider when making a decision on approving an acquisition, and provide that the regulations adopted by the commission will apply prospectively.
All right.
Madam
Delegate.
Chair,
Mhm.
thank you. This bill is the result of legislation that was enacted last year, but we also asked the Health Services, the commission to have a study. There was legislative participation by the providers and by users on that subcommittee. This bill with amendments is the summary, is the result of the work of that commission, and the amendments and the bill were adopted unanimously. I therefore would move the amendments.
They've been moved in second. Any questions or concerns? Seeing none, all those in favor say aye. Any opposition? Seeing none, on the bill as amended? It's been moved in second. All those, any questions? All those in favor say aye. Any opposition? Seeing none, let's go to House Bill 1194, clinical staffing committees and plans, favorable with amendment, Aaron and Bagno. Aaron.
There's a reprint of this bill on page 77. These amendments strike the bill as introduced and instead require that hospitals establish and maintain a clinical staffing committee that has equal membership from management and employees, that each clinical staffing committee must develop a clinical staffing plan for the hospital that establishes the appropriate number of clinicians needed to administer quality health care by setting. And in developing the plan, the committee must establish, based on the patient population of the hospital, suggested guidelines or ratios, matrices or grids indicating how many patients should be assigned to each registered nurse by unit or setting, and the number of registered nurses and other clinicians that should be present on each unit during each shift. To the extent practicable, the guidelines must be based on national evidence-based standards, and on or before July 1st of each year, each hospital, through their committee, must conduct a review of the staffing plan to evaluate the effectiveness of the plan and update the plan to ensure that it continues to be appropriate and effective. The bill also does not apply to state hospitals. And there is an additional amendment that was added in the subcommittee on page 80. And this applies to the current requirement that hospitals provide annual training to patient care staff members to ensure the staff's knowledge and understanding of the patient's Bill of Rights. And this amendment requires that training be provided by staff members, or if they're unable to provide this training through staff members, by contracting with a third party.
Okay. Delegate Bagno.
Thank you, Madam Chair. So these were not consensus amendments, but the subcommittee felt that it was important to move the bill, given that this is an attempt to bring more stakeholders into the conversation on guidance for staffing ratios. It was not unanimous, but did pass subcommittee, and I would move the amendments.
The amendments have been moved in second. Is there any discussion? Delegate Kipke.
Thank you, Madam Chairman.
You're welcome.
Unlike what I sense as a majority of the committee, I have a philosophical disagreement with us meddling in people that run these hospitals, but I'm curious why we would exclude state-run hospitals from this provision. If it's good for the goose, it's good for the gander. We've had testimony over the years from state-run hospitals. Perkins comes to mind, where they have really difficult staffing issues there as well, in all areas of staffing. So I'm just curious, why would we not include state hospitals, which frankly, considering the difficult circumstances in which those state hospitals operate and the challenging patients that they look after, it seems to me that it's even more critical that they would have their staffing issues included in this.
Thank you, Delegate Kipke. Delegate Bagno.
Thank you, Delegate Kipke. So Marie Grant from the Health Department did speak to this a little bit about, concerns about the fact that they were oversight as well as the authority. But it's also, I reached out to her as well to have a longer conversation, and it's by and large because all of our state hospitals are dealing with behavioral health. And so the ratios are different, the staffing is different, the guidelines are different. And I don't think there is a resistance to considering that, but not in this bill. Because right now we have challenges at our state hospitals in that we don't have capacity out for a non-forensic patient. So we need to look at that, but we need to look at it through a different lens.
Okay, Delegate Vice Chair Collison.
Thank you, Madam Chair. So I don't know that it's actually happening, but back in my first term, I passed a bill that required this kind of committee in all the state hospitals, not specific to staffing, but to general operations. And so there is a requirement, a statute that those state hospitals operate in this way. I don't know that it's actually happening, but it does exist.
Okay, thank you. Any other concerns or questions? Seeing none on the amendment, have the amendment been moved? Can you move them? Is moved in second. We had a discussion. All those in favor say aye.
Aye.
Any opposition on the bill as amended? It's been moved in second. Any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposition? Can you raise your hand? Delegate Shalega is excused. We have Delegate Chisholm, Morgan, Riley, Hutchinson, and Kipke. So let's move on to 1327, please. Maryland Department of Health Body Altering Aesthetics Advisory Committee. It is favorable with amendment. It is Lisa and Rosenberg.
This bill establishes the Body Altering Aesthetics Advisory Committee within the Maryland Department of Health. The advisory committee is chaired by the Secretary of Health or the Secretary's designee. It must meet at least twice each year. A member of the advisory committee may not receive compensation, but is entitled to reimbursement for expenses. There are amendments that add the chair of the State Board of Physical Therapy Examiners to the advisory committee.
Okay, Rosenberg.
This is a committee to decide whether we need a commission. These are dealing with a variety of medical techniques, including biomechanics, bioengineering, and biohacking. No one on the committee felt the need to take the rule. It was unanimous.
All right.
Went right over.
So the amendments have been moved. Second, all those in, any discussion? Delegate Hill.
Just wanted to weigh in. I think it's fine. I've spoken to the sponsor. I'm not sure this gets at, I think what the bill is doing and what the witnesses testified to are totally different things, which doesn't mean this isn't important to do. So we'll see what they come up with. But those witnesses were what looked to me talking about ecotourism, probably unqualified physicians performing their surgeries, because any qualified board certified plastic surgeon knows how to handle their own wounds, and the fact that they were having treatment in hospitals during COVID. So there are a bunch of other issues that we heard in the testimony that are not going to be addressed with this, but that's a, bill for another day.
All right, thank you very much. Any other, Delegate Martinez?
I just want to thank Terry and I look forward to working with you on those issues. Thank you.
Okay, thank you. All right, Delegate Hill, Delegate Martinez, thank you for working on those issues together. All right, the amendment has been moved in second. All those in favor say aye. Aye. Any opposition? Seeing none, the bill has been moved. Second, are there any questions or concerns? Seeing none, all those in favor say aye. Any opposition? Seeing none, who does not want to be on the bill? Delegate Riley. Oh, Delegate Riley is a no. Okay, was that it? Okay, all right. And Shalega is excused. All right, so Riley, no for that one, Shalega excused. 1337, Delegate Woods. Oh, who does not want to be on that bill? Can you raise your hand on the Martinez, 1327? I have Chisholm, Morgan, Riley, Hutchinson, and Shalega is excused. Okay, does not want to, she's excused, sorry. 1337, Delegate Woods, Health Insurance, Appeals and Grievance Process, Reporting Requirement, and Establishment of Work Group. Favorable with amendment, Lisa and Collison. Lisa.
sorry. This bill expands the required contents for the quarterly report each carrier must submit to the insurance commissioner regarding appeals and grievances. It also requires the Maryland Insurance Administration and the Health Education and Advocacy Unit of the Office of the Attorney General to jointly establish a work group to study the appeals and grievance process for health insurance claims.
Work to kill this bill across the street. They gave me their word, right? And that they would help get it through, that they will be at the table. I spoke to Matt and that he would testify in support of it to get it through the next house, okay? I'm gonna take their word. That's all we have here in Annapolis, okay? Was that the amendment? So we're having done the amendment. So can we move the amendment, please? They removed in second. All those in favor say aye. Any opposition on the amendment? Seeing none on the bill as amended. It's been moved in second. All those in favor say aye. Any opposition? Seeing none, the bill passes. Who does not want to be on the bill? All right, House Bill 1396, Drug and Alcohol Treatment Program, Discharge of Patients and Referral Services Standards. Favorable with amendment, it is Aaron and Bagnell. Aaron.
There is an amendment on page 83 that strikes the bill as introduced and instead requires the Department of Health to conduct a study regarding the linkages between the various levels of care within the substance use disorder treatment and recovery continuum of care. The study must examine linkages from high-intensity outpatient treatment programs to a patient's need for comprehensive services, including additional treatment, housing, and other social service supports, and existing requirements related to discharge planning and accreditation standards, statute, and regulations. The department must make recommendations about improvements to existing discharge and linkage requirements and improvements to the process of enforcing those requirements, and they'll report back to Senate Finance and HGO on or before December 1st, 2024.
Okay, Bagnell.
Thank you, Madam Chair. And I just want to take a moment and say thank you again for being very gracious that I was so moved by the subcommittee that I inadvertently broke protocol and I did not mean to. But the subcommittee fought to move this bill and it was unanimous and I would move the amendments.
Okay, any question or concerns on the amendments? All those in favor say aye. Any opposition on the bill as amended? It's been moved in second. Any questions or concerns? Seeing none, all those in favor say aye. Any opposition? All right. Does someone want to be on the bill? Who does not want to be on this bill? Okay. 1476, State Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists. Favorable, Lisa and Rosenberg. It's been moved in second. Any questions or concerns? Seeing none, all those in favor say aye. Any opposition? Seeing none. House Bill 1497. It has amendments. Okay, the amendments having 14, no, that we did that already. 1497. 1497. That's the amendments. Can you move the amendment, someone? It's been moved in second. Any questions or concerns? Seeing none. All those in favor say aye. Any opposition? Seeing none on the bill as amended. All those in favor, any questions or concerns? All those in favor of the bill as amended, say aye. Any opposition? Who does not want to be on the bill? And I want to thank Delegate Shalega for your input on the fees, okay? Oh my God.
That's 1490. Yeah.
We're in 1498 now.
That's
1 second. State Board of Massage Therapy Examiners. It is favorable. Can you, Lisa, can you explain what it does, please?
Are you sure?
Yes, because we have a question from Hill. Go ahead, Delegate Hill has a question. Go ahead. $97. Lisa's gonna explain it. Hill, can you give me a minute, please? Lisa.
So House Bill 97 alters the definition of practice massage therapy to include certain techniques. A former licensee seeking reinstatement of a license must, in addition to other requirements, submit to a criminal history records check. And then there's a requirement that the board can require an applicant or a licensee to submit to an examination. This is that's general language that's in most of the other boards. And the amendment removes massage cupping from the definition.
And we had this bill hearing yesterday. There was no one that came against it. It is a board bill that is requested. It is needed because they're having a lot of problems with this board where people are being trafficked, where people are doing what is not correct. All right, no, it was moved and we voted already. Let's go on to House Bill 1498.
That's the one that.
And that's the one that I just described. Okay, so that one has been moved and second. All those in favor say aye. Any opposition to those two, to that board bill? Seeing none? Who does not want to be on the bill?
No, that one's favorable.
Oh, it's favorable, okay. All right, the last one, 1521, Maryland Children's Health Program, eligibility and administration. This is an emergency bill. It is favorable. It is the one that we heard yesterday by the department where they want to get rid of these co-payments.
Second.
All those in favor say aye.
Aye.
Any opposition? All right.